I'm Dr. Pete Littler. I'm an interventional radiologist, specialised in interventional oncology, and I work in Newcastle. And I'm pleased to be joined today by Professor Afshin Gangi from Strasbourg and London. Thanks for joining us.
Pleasure.
So it's just interesting, what is the sort of new areas that we're encountering in interventional oncology? What are the developments there?
I think, in interventional radiology, interventional oncology is the newcomer, which is growing very fast and attracting many young people coming. The clinical service we are providing is essential. We see the patients, we treat the patient, we follow them up, and we have our own beds, recovery, everything. So we are really very parallel to surgery service, and we are providing the same thing. That's important. As a clinical service, that's important. The newcomers, we have seen we have more and more treatment. We had first just some palliative treatment at the beginning, alcohol, some heating, some nerve block. Now we are treating the tumors with hot, with cold, with non-thermal, with embolization, with chemoembolization, with different drugs, with radioembolization. And now we have even the new technique of chemo and bleomycin and electroporation. All this stuff are coming every day. And every of those techniques have a precise indication, combined sometimes with the others. And we are proposing this in a multidisciplinary team for the patients with oncologists, surgeons, radiotherapists, anesthesiologists, clinicians. Means that's a multidisciplinary teamwork, and that's make a lot of fun because we are all together for the best of the patients.
Yes, so it kind of fits into the jigsaw of options open for each patient, sort of personalized approach.
I think this personalized approach has changed everything, because what is the goal of interventional oncology today is we have so many techniques, so many new techniques proposing the patient. What is missing, as we were discussing just before, Pete, is evidence.
Yes.
We need more evidence. We need more reproducibility. We need to have a standard that everybody works quite the same way, like radiotherapy, like oncologists, and we want to come in the guidelines. We have already succeeded to come in few guidelines. For example, for desmoid tumors, ablation is part of the guidelines now, and even I hope soon after the next research we are doing actually, and prospective randomized study with medical treatment, we will perhaps be even the first line in this case. This is the goal, that everywhere in the world we propose a treatment adapted and personalized to every patient. We analyze every patient and we propose them what is the best for them. That's what you're missing now in interventional oncology: standardization, come in the guidelines, and reproducibility.
Yes, and we need to work on getting robust evidence to get the treatments recognized and adopted as sort of gold standard approaches for treating these patients.
I think this is our weakness, but we are working hard on it. And all new interventional oncologists is a very good clinician. Because when we are sitting in the multidisciplinary team, we understand exactly the language and vocabulary of every part of them. Pathologist, who is telling exactly what is the genetic, the molecular of this tumor, which will react to the chemo. No, it's not reacting, take it away, do a thermal ablation, do a chemoembolization, do a radioembolization.
Yes.
We should understand the oncologist treatment. We should know about this. And being in the multidisciplinary team, sitting, you learn every day.
Yes, that's true.
That's really interesting to be part of it.
So there's potential for more sophisticated sort of assessment of the tumours, so we can target specific treatments at tumours that we know are likely to respond. So that's all sort of coming, isn't it? Really?
Absolutely, and that's, being there. They think of you. You know what I mean? What you don't have, you don't need.
Yes.
That's always like this, the same thing. So we are sitting down, we are proposing your treatment. And in many cases, there is a small, competition between treatment, radiation, us and things. But, the best is that to propose the best for the patient. We are not fighting for the patient, we are proposing. And many cases, we are combining treatment. That's the most important part for this. Our weakness, in my point, is the number.
Yes.
You know what I mean? You are not providing enough interventional radiologists and interventional oncologists to be able to propose the same technique in every city. In every
Yes.
big city in UK, we have interventional oncologists, but you go 100 miles, there is no one anymore.
It's a big challenge, isn't it? So sort of postcode lottery, really. So it's trying to tackle that so you have a sort of uniform service across the country so people can access the right treatments.
Exactly.
Not just the treatments that are provided in that area or that.
Exactly. I'm always telling, 3-star Michelin restaurant is good. But if you're not able to reproduce what they do and to propose it to many, many people, everybody has access to this, that becomes a hunter story, That's a hunting story. It's not reproducible. What we are doing once is standard, and we can propose it quite everywhere, every 200 miles, of distance, people can get access to this treatment, that becomes standard. And people can really have access to this, and we will do really and change the field.
That's fantastic. So it's really developing the workforce, getting the research there, getting things adopted, and delivering the service, really.
Our three missions, as we said, clinical service, education, and research.
Yeah.
This is part of it. If we want to progress, these 3 points are connected together.
Fantastic. Thank you very much. Thank you, Afshin, for joining us today.
Thank you.
Thank you.